Welcome, everyone. I'm Dick Deming. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. We have a special guest tonight, but he's actually still seeing a patient, so it's going to be a few minutes. Um, Dr. Ben Miller is orthopedic oncologist, orthopedic surgeon, and the head of orthopedic oncology at the University of Iowa Health System. And he is going to be our guest. We're going to be talking about orthopedic oncology, various different types of cancers involving the bones and the muscles. But we're going to take a pause for a few minutes until he comes back. I should also tell you that if you're watching us live, it is the last Wednesday that we'll be having a video podcast here in December. The next two December Wednesdays, the 24th and the 31st, we will be off. So we won't see you back again until January. So we're going to just put a little pause here until Dr. Miller is able to join us, and we'll be right back. Hello, Ben. Oh, here we go. Ben's calling me. Hey, Ben,
Yeah.
can
Can
you
you
hear
hear
me?
me?
Hey,
I can hear you. Yeah. Can you hear me?
good. Thanks so much for joining us.
Okay. Am I coming through okay? I know I was late. I
Yeah,
missed the
we can see
missed the
you
mic
fine.
drop.
We can
So,
hear you
okay, good.
fine. You look great. So we are back live now. So our guest, Dr. Ben Miller, has just joined us. So Ben, first question: tell us what the what, what a day in the life of an orthopedic oncologist is like today. Were you in the
Yeah.
operating room today?
I wasn't today. Today was a little bit of a different look. I are you am I still with you, Dick?
Yep, yep.
Okay.
So you will switch back and forth. So we've got a production crew that's handling this, and
Okay. I got it. So, yeah, you disappeared for a second, but I'll know that that's no problem. Okay.
no problem.
Yeah, so my week is it's broken up a little bit, which is actually why I kind of got into to medicine to begin with, is to not get bored. Actually, I started when I was an undergrad. I was an engineering major, which was nothing wrong with engineers, and it teaches you how to think, but every day kind of seemed like the day before it. And so, being an orthopedic oncologist means a couple days in the week in the operating room, a couple days a week in clinic. And today is a bit of a potpourri type day. So today in the morning, it was some meetings, some resident conferences, our tumor board. And then in the afternoon, it was kind of little side projects, different meetings that I have, and I do have an kind of an academic look as well. So also doing some research and some writing, and that's what I was doing here this afternoon.
Okay. Did you see any brand new patients today?
No, not today. So Wednesdays are the exception where I typically don't. We talk about in tumor board, we talk about some of the people that we've treated recently, but tomorrow actually will be my big clinic day. So tomorrow,
Okay.
I'll see somewhere 30 to 35 patients in the whole day, and about 10 of those are patients that I've never seen before, new
Brand new.
patients.
Yeah.
Yeah.
So it's been a while since you've been on our show. So let's get to know you a little bit for those who don't know you. So Ben, where did you grow up? High school days. Where did you where were you living during
Yeah,
those
so
formative years?
I'm an Iowa native, and specifically an Iowa City native. So I
Okay.
grew up. So I work here at the university, and I went a long ways, I would say, to not go too far. So I ended up in my hometown, which is a great place to be. I got to say, like I appreciated growing up in Iowa City. I appreciated growing up in Iowa. I think it's a great place. Honestly, when I left, I wasn't sure that I would ever be back. Not because I didn't like Iowa or Iowa City, but because the world's a big place. And so,
Mhm.
what's the likelihood you're going to end up in the same place that you started? So I went to high school at West High in Iowa City, and then I went to college at Cornell University out in New York State. I came back here for medical school, and then I did my orthopedic residency at Rush University in Chicago. And then after my residency, I actually took a year off, and I volunteered and worked overseas for a year. And then I came back and did an orthopedic oncology fellowship at the University of Florida. And then I found a job, and my first job out of fellowship was working at the University of Iowa. And it was just, I got to say, it was serendipity more than anything else. There's not a lot of orthopedic oncologists in the country. There's only about 250 of us. And so when you're looking for a job, it kind of depends on, who's retiring, who's looking to add a
Mhm.
partner, those kinds of things. And it just worked out that I was looking for somebody. I thought it sounded like a great job. My wife is from Chicago. It was close to Chicago. And so everything kind of fit. And nearly 16 years, so 15 and a half years later, here we are. And it's great. So it's a great job. I'm happy to be here. And it really, in retrospect, it seems like everything just kind of fit into the place the way that it should.
And as you mentioned, there's only about 250 orthopedic oncologists across the country, so it's not very common. How did you find your way to this? So you said you started off in engineering at Cornell, and somewhere in those 4 years at Cornell, you switched to medicine. How did that happen?
Yeah, it's an interesting question. I feel like The pathway to medicine, when I was in high school, I didn't really know what I wanted to do. My family is not medical. And I mean, you're aware like of medical professions. But it wasn't really something that I was thinking seriously about. I was good at science and good at math. And so I think, you talk to a high school guidance counselor and they tell you to be an engineer. And so that sounded like an okay thing to do. And then so I was an engineering major. I was in chemical engineering. Then I started to be interested in biomedical engineering. And I kind of put two and two together and said, well, I can kind of see where this is going. So I actually shadowed Pat Hitchon, who's a neurosurgeon here at Iowa. And one of the neat things about growing up in Iowa City is a lot of your neighbors are, your university professors and employees. So he was a neurosurgeon. I grew up the street from where he lived, and so he was an early conduit into kind of seeing what the life of a doctor and a surgeon was. And I really, as I alluded to before, I really like the variability. So I like the aspect of not every day is the same. You're presented with new challenges. I felt like I said, engineering was a great background because engineering is all about problem solving, and being a doctor is all about problem solving. And so, yeah, so then I kind of halfway through college, I felt like maybe I wanted to be a doctor rather than an engineer. Took some biology classes that were outside my major, and did all the things you're supposed to do, take the MCATs and apply for medical school. And then, so I wanted to be a doctor first, and I thought I might want to be an orthopedic surgeon. And that was kind of, preseason number one, I would say. And I did research my first year after medical school with another doctor who grew up in my neighborhood. I'm just realizing this now, but it was quite quite a high density of influential medical people in my neighborhood. But this other neighbor that I had was the chair of orthopedics, Jody Buckwalter. And so I did research with him the summer after my first year. I said, I think I like orthopedics. And ended up going into orthopedic surgery. And that's when I went to Rush. And honestly, I didn't know orthopedic oncology was really a thing that much. You think of orthopedics, you think of sports medicine and joint replacements and spine surgery. But I started to do rotations in orthopedic oncology. I really felt that it was an interesting field. It was interesting academically. It was challenging. And one of the things that really drew me to it is when I was a junior resident, you're very busy as a second year resident. It's in most places, it's the hardest year 2 out of 5. You don't know that much. You're on call a lot. It's a steep learning curve. You're working really hard. Nobody ever says thank you. It's just a really tough year. And one thing that I found is even when I was like really tired or a little bit irritated, I always had time for the orthopedic cancer patients. I just felt like a real connection to them. I felt a real sense of injustice, people suffering from cancer in general and musculoskeletal cancers specifically. And that just seemed to be the area. Again, I wasn't really aware of it in present time, but when I look back on it retrospectively, it seems absolutely inevitable that I would have ended up here. And interestingly enough, my former neighbor, Dr. Buckwalter, who was chair of the department, was also the orthopedic oncologist at Iowa. So he turned out to be the one that hired me as his junior partner.
Wow.
So as much as things can go full circle, that one did as well.
Yeah. And for those who might not know what orthopedic oncology is, give us a brief definition of what orthopedic oncology is, and that's probably would include the types of patients that you see.
Sure. Yeah. So most people, I think, would know when you treat cancer, there's kind of 3 types of doctors that you need. So maybe the most obvious is the oncologist, and more specifically, you would call them the medical oncologists. So these are the people that would give what they like to have us call systemic therapy. So many people know it as chemotherapy. I think oncologists would be quick to say, wait a second now, we don't give chemotherapy. There's lots of other targeted medicine we can give, and immunotherapy and things that don't make you feel so bad. So the medical oncologists are one aspect of treating cancer. There's like you are, Dick, a radiation oncologist. So that's another type of oncologist, not a medical, but a radiation oncologist. And that's one of the main things that we do is deliver radiation treatments to cancer patients. And then sometimes you need a surgeon. And so I'm the surgeon component of oncology and specifically focused on the pelvis and the extremities. So I would be different from maybe a general surgeon, general surgical oncologist that might take a cancer out in a kidney or in a liver or in a colon. I would take a cancer out in the bones and the muscles and the soft tissue of the arms and legs and pelvis. And so the kinds of, what my practice looks like, is it's really variable. And I looked this up a few years ago. If you were to say my practice consists of 100% of something, about 20% of that is a rare kind of tumor called a sarcoma. And that's something that is it's a rare cancer. It's 1% of all cancers. I'm sure we'll get into sarcoma because you and I have several patients in common that we've managed with this. And that's where a lot of our brain power goes. How do we better take care of people with sarcoma? About 20% of what I deal with is people with metastatic disease. So people that would have like a lung cancer, breast cancer, or lymphoma. These can spread to the bones. And then if the bones are at risk of breaking, or if they have broken, then you need somebody who's not only specialized in cancer, but also specialized in orthopedic surgery to take care of that. About 40% of what I see are benign tumors, so little lumps and bumps. And thank goodness most of the bumps that people have are benign. They're not cancers. So these are things like lipomas, fatty tumors. We see a lot of bone cysts in children, things that aren't going to spread, aren't going to kill people, but they can still cause pain and discomfort, and people don't like them. And it's still good to have some expertise to take that out. And then the other 20% of my practice is what I would call maybe miscellaneous, like weird infections. We don't quite know what's going on with this patient. And those are actually pretty interesting too, where it's not a run-of-the-mill orthopedic condition and we're not totally sure what we're dealing with. And then sometimes they'll ask me to take a look and see if I can contribute something to that.
And Ben, what percentage of your patients would be like under the age of 18? Because some of the sarcomas and some of the osteosarcomas happen in teenagers. Do you have a certain age group? Do you sometimes treat very young children?
Yeah, we do. I think this last year I've treated a kid who was about 3 months old, and I treated somebody who was 99. So
Oh,
so we
wow.
run the spectrum of everybody. Just as a general rule, more older people get tumors and cancer. That's just kind of a fact of being a human being. The longer you live, the more your cells can divide, the more likely something's going to pop up. But we do, as you allude to, there are certain tumors and cancers that have a predilection for a younger age group. And so if I look at my practice, it's about 15 to 20% of my patients are under 18. But most of them are still grown-ups and adults, but we definitely take care of the kids as well.
Well, let's talk about some of the cancers in particular. So let's start with sarcomas, since that represents a sizable part of your job. So we kind of generally talk about soft tissue sarcomas and osteosarcomas. Maybe give a little bit of a primer on sarcomas and how they present.
Yeah. Well, sarcomas is, take your pick. How are they going to present? One of the difficult things about studying sarcomas are, in almost any research project you have that deals with sarcoma, you come out at the end saying, well, we're limited because sarcomas are rare and sarcomas are heterogeneous. And what that means is we don't see them that much, and they come in a lot of different forms. And so sarcomas just there are over 50 kinds of sarcomas. I think you could safely say there's over 100 or maybe even over 150 types of sarcomas. So these are all the different subtypes. So it's not just one disease, like melanoma is kind of one disease, or myeloma is kind of one disease, but sarcoma, it's just kind of a mishmash of a bunch of different tumors that tend to start in the I have one of my colleagues describes it as Dr. Mo Milham, who is my medical oncologist I work very closely with, kind of talks about sarcomas being the fillers. So you have the blood tumors, like the leukemias. You have the carcinomas, which are the linings, either your exterior lining or your interior lining of your body, and then all the stuff that fills your body. So the fat and the muscle, and the bone and the blood vessels and the cartilage. So all of those tumors just kind of get grouped into sarcoma. But you can imagine they show up really differently. So if you have a tumor in your muscle, you're going to handle that a lot differently than a tumor in your bone. If it's really small and close to the skin, you handle it a lot differently than if it's really deep and big and close to a lot of important nerves and blood vessels. So sarcoma can kind of present any way that it wants to. The two main categories that we divide sarcomas into are bone and soft tissue. So that's the easiest way kind of to think about it. Does it start in the bone? Does it start in the soft tissue? Bone sarcomas, the most common ones, are osteosarcomas, Ewing sarcomas in kids, and then chondrosarcomas. Those are most of what we see are those big three. And then soft tissue sarcomas, there's many, many more kinds. Most of what we see are called undifferentiated pleomorphic sarcomas, which is kind of almost fancy doctor speak for saying we don't really know what these are, but they don't look very good, and we're going to call them a sarcoma. But those two, if you make those two groupings, then it kind of tells you how to treat them and who needs to be involved in terms of the medical oncologist with chemotherapy or systemic treatment, radiation doctor to give radiation, or a surgeon to take it out. Most sarcomas present as a mass, so a lump that you can feel, especially soft tissue sarcomas. The ones we worry about are the ones that are growing fast or the ones that are really large. Those are ones that we take really seriously. People can have a lot of lumps and bumps, and I mentioned lipoma, and I don't want this podcast to scare anybody, because most little soft tissue masses are nothing to worry about, and especially if it's small, if it's close to the skin, if it's painless, if it's been stable, meaning it hasn't been growing for a long time, you don't need to worry about it too much. It's really the ones that are growing rapidly that we want to assess and make sure it's nothing going on. And then for bone tumors, it's mainly pain that people present with. So, and people can have pain here and there, but we're talking like significant pain that's getting worse, pain that wakes you up at night or is present at rest. Pain with activity for people whose bones are involved, and maybe the bone's getting weak. If you're starting to have to use crutches because it hurts so much when you put weight on it, those are all things that we'd want you to see somebody and get an X-ray right away.
One of the other differentiators is we often refer to extremity sarcomas as opposed to truncal sarcomas. So historically, I mean, if somebody had a tumor of an arm or a leg, surgery could be just removing the arm or leg. Obviously, those are important parts of the body that people don't like to lose. And so during your career, my career, a lot has been done to talk about functional preservation. And part of that has then brought into the sarcoma treatment, the use of systemic treatment and or radiation therapy, maybe upfront, or trying to help reduce the size of the tumor, allow you to be successful in getting rid of the tumor, but still allow the patient to have not only still have a limb, but a functional limb.
Yeah, I would say that's exactly right. So this maybe even predates my start a little bit. The transition from amputations, as you say, there was a time in human history that was not very long ago. I mean, we're talking like 1960s, 1970s, where if somebody showed up with an osteosarcoma, there's not a whole lot that you could do. This is even pre-chemotherapy, it's pre-MRI. I mean, think of all the tools we have now that we didn't have before. And so the way you treated, say you had an osteosarcoma in your knee, and it's 1960, the way you treated it is you had surgery only, and that surgery would be an amputation, and then you would cross your fingers and hope that the tumor didn't show up anywhere else in your body, and you would be cured about 20% of the time. So it was really like pretty miserable time to have an osteosarcoma, and that was not that long ago. 1960, like I wasn't alive. I think a lot of I was pretty, yeah, but yeah, I was alive soon after that, but 1960 I wasn't alive. But yeah, now we think a whole lot about about functional outcomes, pain relief, what's going to give durable survival, in addition to curing the cancer. And I kind of frame it as, we have two big goals in the cancer world. One is we're trying to make lives longer, right? That's the thing we always think about. Can we cure people? Or, if we have something that can't be cured, can we give a duration of survival? But the other thing that I think gets minimized a little bit, which is really, really important, is we want to make lives better, right? And so a lot of the effort that we have in orthopedics is going along that route. How do we give a better reconstruction, a more durable reconstruction, minimize complications, minimize pain? And I would say, sometimes it's an interesting thought, but when I think about um, the um, the role of orthopedic surgery or surgery in sarcoma, um, we've actually over time, I think, become worse cancer surgeons. And let me explain what I mean by that. Is I think we have recognition that surgery is a necessary but not sufficient part of taking care of cancer. And when people die of sarcoma, they're not dying because our surgery was inadequate. They're dying because the tumor has already spread to other places in their body. And most notably, it goes to the lungs, it can go to bones, it can go to lymph nodes. But there's no surgery big enough that's going to take care of that when the tumor is
Mhm.
already spread. And sometimes we can't see it. We call this micrometastasis, where we know there's cancer cells swimming around somewhere, but we don't know where they are. And who's going to help us with that is the medical oncologists and the biomedical researchers finding better systemic treatments and new drugs to help us cure cancer. So for us, what we do as surgeons, since bigger surgery doesn't necessarily relate with better outcomes and better survival, now we're focused on, well, what's adequate surgery? Like, what can we do to get that necessary component of taking the tumor out, minimizing local recurrence, which is the tumor growing back, and maximizing function? And so
Right.
that's where we come into things like, can we use an MRI to be safely as close to the tumor as we can possibly be, so that our reconstructions can be better and give people more function? That's why we bring people like you in to give radiation treatments to say, can we sterilize the edge of the tumor and improve our margins and minimize local recurrence, and also salvage limbs and salvage important structures and give people better function? So that's really where my field has been these last 30-40 years, is trying to really focus on the operation to, yes, do the necessary work to remove the cancer where it started, but really to optimize function, quality of life, pain control, and
Yeah.
durability.
So, two really important points you made is one, if an individual dies of a sarcoma, it's not because of the local sarcoma, it's because of metastatic disease. And then the other important point is function. And so, get back to the extremities. Um, Clearly, a functional extremity is important. Saving an extremity that doesn't work, you may get better function in some cases by doing a partial amputation. I mean, we've all watched the Paralympics and watched people running really fast, with prostheses, and some people have a better quality of life with a prosthesis than they might with a non-functional limb. That must be a really difficult, complex conversation to have. I mean, first of all, you need to figure out what are the blood vessels and the nerves, and how do you take out the tumor and the part of the bone, but you keep in enough and put in reconstruction, and what do you use to reconstruct, but still end up with a extremity that can do what it's supposed to do. And at what point does it come to the point that you really think that you'll have better functional outcome with an amputation and a prosthesis?
Yeah, there's absolutely still a role for amputation. And I got to say, it's not our first choice. We don't, love to do it, but in medicine, sometimes the right answer is something that you don't love to do. The way I think about it, when I approach a patient, I kind of ask myself two questions. One is, can I get the tumor out, right, with a limb salvage? And sometimes you cannot. Like you said, maybe it's involving too much, where you'd have to remove just too much tissue, too many important functional components. You have to remove all the blood vessels and nerves, or maybe the tumor is just too big and there's just no way to get it out. So in those cases, then, an amputation is the right answer. most of the time you could look at it and you could say, okay, well, I think technically I could get this out, right? Even if it's a big operation, even if some critical structures have to be sacrificed, I could still like technically remove the tumor. But then the second question you have to ask yourself is the function of a limb salvage better than that of an amputation? And there's certain situations where the answer is no. The most obvious would be if you think of maybe a sarcoma in the foot or in the ankle. Say you had to remove a bunch of bones, they'd be hard to reconstruct. You have to take some ligaments out. You have to remove a nerve, so you can't feel your foot or you can't move your toes. We do know, as you were alluding to the Paralympics, like people with baloney amputations do amazingly well. It's a great operation. So that would be one where I would really hesitate to say, let's give some person maybe a bad or painful or insensate foot. Maybe that one's better. You do the amputation, you give them a great baloney operation, and you give them a great baloney prosthesis, and they would actually do much better with that. It gets more complex. The general rule of thumb is the higher up you get in the lower extremity, the more important the leg becomes. So below-knee amputees do really, really well. Above-knee amputees still do well, but not as well as below-knee amputees because now the knee itself has to be in the prosthesis. So there's more energy expenditure. It's harder to learn how to walk. Even higher than that, sometimes we're talking about amputating the leg at the hip or taking part of the pelvis. That gets really tough where really patients don't use a prosthesis. It's more difficult to mobilize. It's a lot of time in a wheelchair. So that is the higher you get, the more important doing limb salvage is. And then in the upper extremity too, what I've learned over time is that even a bad hand is better than no hand. And so we'll do a lot. You talked about partial amputation. So even if you can save like a thumb and the index finger, that's going to be better than doing an amputation at the wrist. So we get pretty creative with the upper extremity, trying to give people as much of a retention of function as we can. But your point's a good one. And honestly, if you look at the numbers, amputations are probably still 10% of how we treat sarcoma. For one reason or another, we still feel like that's the best way to treat it or to deal with the complication. Bad infections and tumor recurrences, things like that can happen as well. And when that happens, sometimes amputation is the right answer.
One thing that we've seen in most oncology, and orthopedic oncology is no exception, is the moving the chemotherapy, radiation therapy up front. So traditionally in cancer care over the last century, it was surgery first, and then figure out, do you add chemotherapy and or radiation afterwards? And in many types of cancers now, it's switched, and we might start with chemotherapy first and see what sort of response you get. And if you get a good response, it may actually facilitate and make the surgery easier. A lot of that has happened, during your career, your 16 years on staff, but even during your training as you started, you're probably starting your training at the point at which we were starting to bring chemotherapy up front as opposed to after surgery.
Yeah, the chemotherapy up front, the best example of that is an osteosarcoma. It's an interesting story. It kind of parallels when we started going away as this was predated me a little bit, but the global we in orthopedic oncology started to move away from doing amputations in everybody and starting to do limb salvage. And there were a couple things that had to happen there. So things like MRIs came about. We don't think about MRIs that much anymore because they're just kind of everywhere. But if you think before, the time where there was not an MRI and now there is an MRI, what an MRI allows you to do as a surgeon is it tells you exactly where the tumor is. And it's really an unbelievable test, to look on the inside of somebody and to say, like, as a surgeon, I'm always thinking about, well, what structures can I save? Where do I need to cut the bone? And the MRI can tell me, and I can trust that what I see on the MRI prior to surgery is what I'm going to see eventually in surgery and with the final pathology to get negative margins. So chemotherapy was the other thing that really helped with that. So if you give chemotherapy and it can kill a portion of the tumor or it can sterilize the outside of the tumor, then you're more likely to have a negative margin, less likely to have a local recurrence. And interestingly, the way chemotherapy up front came about, because it doesn't make a ton of sense. Inherently, if you were to say, well, when are you going to give chemotherapy? It almost makes more sense to say, well, take the tumor out first, get that tumor out, and then give chemotherapy afterwards. But what happened with osteosarcoma is when they started doing limb salvage, one of the things when you have a bone sarcoma, when you take the tumor out, you're also taking a bone out. So it's a little different than soft tissue sarcoma. A lot of times with soft tissue sarcoma, you can just take the tumor out and then you're done. You sew it back up, but there's no real reconstruction that you have to do. But with the bone, for the most part, you can't just be done, right? You have to figure out what you're going to do. And one of the things you can do is you can put a big metal prosthesis in. And nowadays, when we do that, these are all what's called modular prostheses. And what that means is we have a bunch of potential implants that we could use. Really, they're all in sterile boxes. And then we take the tumor out, and it's almost like building up Legos, right? You can say, well, what do we need to build up to fit what we took out? So that's called a modular prosthesis. And it's nice, it's easy to use. But that's kind of a newer thing, in the last several decades. But when they first started doing limb salvage, you didn't have a modular prosthesis. You had to build a custom prosthesis. So you had to find an implant company, and you had to say like, hey, I need a prosthesis that's 3 inches long and this wide, and a stem that goes up into the bone, and this is what I need. And they say, okay, we can build it, but it's going to take a couple months to build it. So as they're building it, you don't necessarily want this cancer to go unimpeded growing in somebody. So you say, well, let's do something. So they say, okay, well, let's give chemotherapy while we're waiting for the prosthesis. And what we find giving chemotherapy is sometimes it makes the surgery easier. Sometimes it sterilizes the border. And then actually the response to chemotherapy is a very good prognostic sign. If you have a good response to therapy, your likelihood of surviving your cancer is much higher than if you have a bad response to therapy. So it also gave us some information, and now has become absolutely the
Right.
standard of care. If somebody said, I don't want to do chemotherapy, just do surgery, you'd say, what are you talking about? Like that, nobody does that.
I had no idea that it got started because you needed some time to get the
Yeah.
prosthesis made. Wow.
Yeah.
What about 3D manufacturing of prostheses that are specifically designed for the patient?
Yeah, totally. That is right. Just cutting edge. So this one truly is something that I've been a part of in my time. So I think the best example of 3D printing is when you have acetabular tumors. So the acetabulum is kind of the other side of the hip joint. So if you think of your hip joint, it's kind of a ball and a socket joint. So mainly you think about the ball, right? That's like your femoral head. And when you do a hip replacement, you're taking the arthritis happens in the femoral head, and you take that out, you put the stem in, that's where the ball is. But there's another side of it too. That's the acetabulum, the cup, and it's part of your pelvis. And it's been a real problem over time when you have a tumor that starts in the acetabulum and you have to remove that, a portion of the pelvis and a portion of the hip joint. It's much harder to reconstruct that. So much so that that there's many patients and a lot of doctors that still advocate that say not doing any formal reconstruction, just trying to get the bones to heal as well as they can is the better answer. And I don't disagree. It's durable. It works okay. But I think we always are trying to make things better. And so there's been a lot of attempts at implants or using allograft, which are donated bones, things trying to reconstruct these deficits, and they really don't work very well. There's a really high complication rate. Most of the techniques have been abandoned. But for the past 10 years or so, we as again, now kind of an international community, have been doing 3D printed custom implants. And it's really changed things. I mean, they're not very common tumors. I've done maybe 15 of them in the last 5 or 10 years, but I've been pretty happy with the results. There's certainly some complications. It's a hard operation. Things can go wrong, but and the people that it goes right in, from my perspective, they're doing so much better than somebody that had to have their entire hip removed and not reconstructed. And so
what's the material that they use? And do they make something in a cast and a mold, or do they actually create with the 3D printing the actual device that you're going to put into the body?
yeah, no, it is. You can, like, historically these were casted, but today a lot of them are 3D printed. And I use a company. I outsource with a company. That's what a lot of people in the US do. But there's a number of people internationally that are figuring out how to actually 3D print implants in their institution. That makes me a little bit uncomfortable. Like I don't think everybody having their own 3D printer in their own hospital is the best way to make sure we standardize care and get the best results. But I understand in people where maybe you don't have the resources to collaborate with the company, and you do have the resources to 3D print something, how that would be a good solution. But yeah, most of them are titanium, 3D printed titanium, and then we've always used cobalt and chrome in certain portions of a prosthesis to strengthen them. But yeah, but they work pretty well. The other thing that you can do when you do these custom prostheses that is kind of adjacent to 3D printing and custom prostheses is using either custom cutting guides, which are things that you can import a CT scan and MRI essentially into like almost like an architectural CAD program, and you can plan, like I can work now with engineers to say, here's where I want to make my cuts, here's what I'm going to be able to see. And then they can say, okay, here's basically a jig that you can put on the bone after you have exposure. It's the cut that we planned prior to surgery, and now you can make the cut that is going to get a negative margin. And now we know once you make that cut and you remove the bone, the custom implant that we 3D printed is going to fit perfectly in that defect. So you can do that with the jigs. You can also do computer navigation, which is basically having a computer inside the operating room, and you can look and see, is the angle of my equipment the right angle? And so these are things that we're now using for these more complex bone sarcomas to try to again, just kind of push the edge of that, right? What is the minimum necessary surgery that we need to do to remove the tumor and get it to not grow back again, so that we can retain as much normal functional material as possible to build a reconstructed limb off of.
So you're describing a very complex procedure. So most people know that, you can go to quite a few community hospitals and get a hip replacement, get a knee replacement, even shoulder replacements are becoming more common. I imagine you need a much bigger, more specialized team in the operating room to do the type of surgery that you're doing, as opposed to a standard hip replacement for arthritis. Maybe describe some of the other team members in the room with you, and not just in the room with you, but as you prepare for the surgery, and then as you then rehab after the surgery.
Yeah, no, it certainly takes a whole team. And I appreciate that comment. And yeah, I have the honor, I would say, of coming out and talking about some of these patients that we take care of, but it's certainly on behalf of everybody that works with me. So I mentioned already a couple. If we just take maybe the situation of like a big pelvic sarcoma, which are very difficult cases, they're called hemipelvectomies. And so for that, it starts with my team in the office. And so, I have an administrative assistant, a research assistant. These people are critical for finding operative time, of getting, a lot of times we have to go through our institutional ethics board, because not all of these implants are, FDA approved or off the shelf. We have to say, hey, we want to do this operation. We think it's safe. We think that this is the best thing to do. I have nurses and nurse practitioners that kind of help me get people ready for surgery. We have a great team of internal medicine doctors and anesthesiologists, making sure that people are safe for surgery. We can get them through safely. In surgery with me, I have typically two trainees. So I have a resident who helps me with this, and then an orthopedic oncology fellow. So there's usually at least three of us in these big cases. I talked about the implant team. So we actually have implant people in the room that help our team, mainly the surgical assistants that I have, saying, okay, he's going to need this next and need that next. But they're also there, troubleshooting if we have any issues with the implant, and reminding me of what the operative plan is, because I'm kind of sterile and scrubbed into surgery. We have a circulating nurse in the operating room, making sure everything is going well. And then we have a surgical tech, who is the one who's kind of handing instruments, who understands what we're doing. And all of these people are absolutely critical. The anesthesiologist in the case, the communication that the anesthesiologist and I have. These patients often need several units of blood transfusions. They go to the ICU afterwards. I mean, they're big. There's not much more you could do to a person than that. And then my surgical colleagues, it depends on the tumor, but it's not uncommon that I'm calling my urologist and saying, hey, this is really close to the bladder, close to the ureters. or we've had radiation, and I think it's going to be a hard dissection, or my general surgeon, hey, this is extending close to the abdominal organs, or it's close to the rectum. Plastic surgeons, hey, I think we're going to need some help getting this thing closed up. Could you give us a hand? So vascular surgeons, God forbid, if you get into trouble with a blood vessel. So yeah, these are not community hospital cases. These are cases that are, I think most community surgeons would say they're happily referred to a university setting to be taken care of.
And then post-op, the rehabilitation.
Yeah.
I would imagine you've got physical medicine and rehabilitation specialists, along with obviously physical therapists and occupational therapists, and
Yeah, absolutely. Yeah, and the challenge there I find with people is, sometimes these big operations, there is so much to talk about that you don't know. You just kind of can't go through everything with somebody, and so if you just imagine the situation that a patient is in when they're first meeting me, life was normal a week ago, right? And then they have a little bit of pain, and now they're sitting in somebody's office who's showing them an MRI and saying, I don't think this looks good. And then they're getting a biopsy, and they're coming back and seeing us and saying, you have cancer, and here's what that means. And all people kind of hear at that point is cancer, and all they want to do is just get the cancer cured. And I certainly understand that instinct, but what I have to know as their surgeon is, once we get the cancer cured, the rest of the things that we're going to talk about their entire life is their function and their pain. And so even though we're not totally focused on those issues at the onset of diagnosis, those become the issues once the cancer is gone. So we need to think about things like that, about the rehabilitation, about the expectations, about the limitations. We tend not to get all that in, before we get to surgery. We just kind of talk about why surgery is needed. They're coming to terms with a really life-altering diagnosis, and we can't throw everything at once. But I just kind of say, you outline what the process is going to be, what the surgery is going to look like, what the hospital stay is going to look like. And then you just tell them, like, there's going to be things that pop up along the line. I'll be there. We'll help you through it. We answer questions. But I always look at things, there's phases of treatment. Like, after these big surgeries, phase one is kind of, let's get your pain under control. Let's get the wound healed. Let's get you out of the hospital. We don't worry so much about, rehabilitation or what life is going to look like long term. After that first couple of weeks, most of the time we're saying, okay, good. You're through it, you're home, or at least you're out of the hospital. Wound's looking good, pain's getting better. Now let's start to say, let's get a therapist involved. Can we get you walking? Can we get you off the walker and crutches? Can we get your joint moving? Can we get you more flexible? Can we get you stronger? And that phase is kind of usually several months of still, rehabbing things. I usually tell people, even for 1 or 2 years, like, it can take that long to recover. Now the curve is steeper right away. Like, they'll notice progress, even day to day sometimes for the first few weeks. But once we get into 2, 3, 4 months after surgery, people can still be a little frustrated. They just feel like they should be recovering faster than they are. And, I tell them, these are big operations. We're changing a lot of anatomy. You're going through a cancer diagnosis. Sometimes you're going through radiation or chemotherapy. It just takes a long time. So I always advise people, don't measure your recovery day to day, measure it like week to week, right? Or even month to month. And because that last bit of recovery, the curve kind of flattens a little bit. And then once we get out to, 2 years, I kind of say, this is probably where you're at, and I got to say, sometimes there are permanent functional limitations just from what we have to do to get the cancer out. So we always, I tell people, like, let's go for perfect, let's shoot as high as we can. Let's work as hard as we can to get as close to what you want as possible. Cause we know that if you're left with less than that, at least you tried as hard as you could. And people are, the human animal is such a resilient animal. They are so able to accommodate their situation, be resilient, to become accustomed to challenges that they have. I just know, I have faith essentially in all of my patients. They're going to find a way to make it work at the end of the day. And
that has to be so inspiring to you to see that the indomitable human spirit that can take on challenges. And
it's so predictable that people just, just given a challenge like this, they're going to come through it. Even if they don't think so, I know it's going to be so. I've seen it. I've seen it too many times to doubt it.
So, Ben, we have a live studio audience here. We also have people that are live streaming. So we're going to turn it over to questions, and the folks in the room here get first shot at you. So, Angelina, you got the microphone. You get the first
Well,
question.
this really hits close to me because I just had an MRI done last Monday. So the no contrast and contrast, you felt like you're in there for 2 hours. I was like, oh, I'm glad I'm done. Oh, no, we haven't done the contrast yet. And I'm like, oh, joy. So, but when you go through the my chart, there's all this gibberish stuff. Thank you. That Dr. Demi is also one of my oncologists. Uh, kind of broke it down, but there's one phrase that kind of sets that I'm guess I'm trying to ask this question. Nerve root, I don't know if I'm saying it right. Sheath tumors, as those are the ones that are considered benign, right?
Hmm. Yeah, nerve
Okay.
sheath tumor. Yes. Yep.
Okay, because my doctor, the medical oncologist, is referring me to a neurosurgeon to look at the forward where to go from there, a spinal tap, or maybe check it in 3 to 4 months. Is there another possibility other than a spinal tap? Do you think that would be? She mentioned another thing, and I forgot.
Angelina, can I add a little something so that
Sure.
Dr. Miller gets the phone? So,
Okay.
it's okay. We talk
Yes,
about yes.
I'm getting
Angelina
permission.
has a history of breast cancer
Yes.
and back pain. So the MRI did not show any bone metastases, but there's some nodularity along the nerve roots. So the differential diagnosis is, could that be cancer along the nerve roots, or are they benign tumor? So that was the finding of the MRI that has now led to the question of how to resolve the differential.
Yeah.
So,
Yeah, it's I'll speak in just broad terms, just with lack of familiarity of the case. And I would say in orthopedics, we always like to look at data firsthand. So I'll take the read of it, and I trust Dr. Deming. He's a good doctor, but having not seen it with my own eyes. So in general, we look at an MRI, and some of it is like your level of suspicion. So what's the history? How, I talked about like a growing mass, or is the history you hear it and you're like, oh my God, something terrible is going on? Or do you hear the history and you're like, I don't know, it's probably nothing to worry about, but let's get an MRI and just, make sure that we're not missing something. And then the second part would be, well, what does the MRI look like? And sometimes, I would say most of the time, and I tell people this, like cancer is typically not a subtle diagnosis. So if you're sitting around scratching your head wondering if it is cancer, that's usually a reasonably reassuring place to be, because there's a lot of MRIs that I look at and I say it's cancer. I don't know. Let's get a biopsy. Let's prove it. But I think we're going to be talking about some kind of cancer and something that we have to deal with. So, when you're in that situation, if something's borderline or indeterminate, there's a couple things you can do. So one is you can do a biopsy. That's the easiest thing to do if it's accessible. Now, if this is in like a spinal nerve root, that might be kind of a tricky place to do a biopsy. So if it's a tricky place to do a biopsy and our suspicion is not very high, then a lot of times what we'll do is just surveillance imaging. So we'll check another image in a few months and just make sure that things aren't changing, because there's a general rule of thumb with cancer. So cancer, for all of its intelligence as a disease process, is kind of a dumb disease process because all it does is grow. It does one thing, it grows. And so if you do surveillance imaging and what you're seeing is something that's not growing, then that's also reassuring that it's not cancer. So I don't know exactly what the doctors have planned for you, but that's the way I would think about it. How worried are you? Are you pretty worried? Well, then, yeah, let's stick a needle in it and see if we can look at something on the microscope. If you're not so worried, maybe just keep an eye on it, cross our fingers, and hope that it doesn't behave in a manner that's concerning.
great. Thanks. Next question, Gary.
Yeah, I thought it was interesting, for these, especially like the hip, the fact that, it can be so complicated. Do you do practice sessions before you, go into surgery to ensure that you get everything correct? I think of it like an astronaut, the fact that they have to go through so many different practices and stuff like that to ensure that, they think they know what it's like, but then things can happen. So,
Yeah.
so do you do a practice session before doing all that?
Yeah, it's a good question. So the best way I can explain that would be that medical training and surgical training is an apprenticeship. So we are exposed. We have 5 years of an orthopedic residency and then 1 year of an oncology fellowship. So the idea there is that that's the time that you can practice. You're practicing because you're observing somebody more experienced than you, or you're maybe doing some steps as you're supervised. And then in terms of, do we practice for individual operations? I mean, when I was first training, when I was in my fellowship and early in practice, sometimes I would actually do some work on cadavers. If I had a tricky surgery coming up, trying to just, make sure that my exposure was the way it was, the way I wanted it to be. Now our form of practice is, it's more mental. I'm going through the MRI, maybe I'm working with a model, I'm, working with the engineers and actually talking about these custom jigs that we make and the custom prosthesis that really focuses your mind, because you're thinking about, what am I going to see and how am I going to do it? But I would say we don't practice on every case. And one of the reasons we don't do that is human anatomy is maintained. So we all look the same underneath the skin. So I just kind of need to know the personality of this tumor, where I need to make the cuts to take it out. But other than that, the femoral nerve is going to be in the same place in everybody, and the hip joint's going to be in the same place in everybody. So your point's a good one, and I would maybe just leave it reassuring you that we take things really seriously, and we do. Nobody's going into this green or not knowing. We're not watching YouTube videos, the night before, wondering how to do this operation. We take it really seriously.
Any role for robotics in orthopedic oncology, robotic surgery?
Yeah, not right now, but it's coming. I think, there's a few things that we can see on the horizon. You mentioned AI, you mentioned robotics, like these things, if they're not totally utilized yet, I imagine by the end of my career, they will be. Robotics in orthopedics are used a lot in joint replacement. So they're used to make the cuts, perfectly align with either surgical navigation or a preoperative plan. So I think in orthopedic oncology, there's probably going to be a role at some point. Right now, robots aren't very good at doing soft tissue dissection, so you still need a human for that. As I talked about, sarcomas they all present very differently. So it's not like a total knee replacement where it's the same operation over and over and over again. For me, every person is different, every tumor is different, every location is slightly different. So you really need the human mind to be able to work through that. But I have no doubt that at some point, maybe in my career, maybe afterwards, but I think at some point there'll be some element of robotic assistance in what I do.
We have time for one more question. Ron, you get the last question.
I'm not sure how pertinent this is, but as more and more people are living with cancer and joint replacements are becoming more and more commonplace, does that pose different challenges for a cancer patient to have a joint replacement? And is that something you do, or is that anyone orthopedic can do that? Or
yeah, it's a good question. I mean, you hit on really one of my favorite topics to talk about nowadays. So maybe I'll circle back to that. One, there's kind of two questions that you could be asking. One question would be, is if you have cancer, is it okay to get a joint replacement because you have arthritis or something like that? And the answer is yes. I would say some doctors might be a little bit wary, oh, you have cancer, maybe we don't replace your joint. That's not the way I feel. I feel like if arthritis is a problem and you need a joint replacement to improve your quality of life, whether you have cancer or not, then that should be something that you talk to your doctors about. One of the reasons I say that is because we're becoming better at, even if we don't cure people, we can provide a high quality of life and a durable survival for many patients. Not every patient, but many patients, we can do that. And so, having the issue, should you have a joint replaced, maybe it was different 30 years ago if a survival was 3 months, but if we think you're going to be around for 4 or 5 years, managing a cancer and just living with a cancer, then yeah, I mean, we should do everything to optimize your quality of life. The second thing that you may be asking is, now that we're better at managing cancer, and this would be not necessarily on the sarcoma standpoint, but in the metastatic disease standpoint, are we thinking about things differently? And the answer there is yes. And it's actually making our job as orthopedic oncologists more challenging in a good way. It used to be, and this is something that's changed in my practice as well. When I was a fellow, I did a research project, and I looked up, we put in, when people have broken bones through cancer, many times we put an intramedullary rod or a nail in it. So that's, many people may know the concept of that. So if you break your leg, say you're in a car accident, you break your leg, a lot of times we put a metal rod in the middle of the bone to bring it back together. Well, that's what we do in cancer as well. And I was trying to look up and say, well, why did these rods fail? And I found that in lung cancer, they never failed. Not one patient in the history of the University of Florida, when I looked it up, who had lung cancer ever had a problem with their nail. And it's not because people with lung cancer, magically healed their bones or they were stronger than other people. It's because they died. And when you die, you can't fail your surgery. And so the problem that we have now is people are living longer. And so where we may have just like done a mediocre operation to say like, oh, this thing only needs to last 6 months. Now we're having to start to think about, we need to do a better operation because this person might be around for years and years, and durability is a big goal that we have, functional restoration, pain relief, but durability. What's the one surgery that we can do that's going to last the rest of somebody's life? And so when we're doing that, it's actually leading us to replace more joints. Because if you have a compromised bone, a tumor's in it, the bone's not very strong, maybe we have to radiate, it's not going to heal very well. It might be better just remove that bone altogether and replace it with a metal prosthesis because they're more durable. So we've definitely changed more in that direction. That's a big challenge for people in my specialty, is thinking about how do we manage metastatic disease of bone and changing environment with, fortunately, the happy problem that people are living longer.
Yeah, right. And especially lung cancer with the mutated targetable mutations, as you pointed out in your study, it used to be rare that someone with stage 4 lung cancer would live even a year. And now with certain mutated lung cancers, they can even live a decade. So, well, this has been great. Dr. Ben Miller has been our guest, orthopedic oncologist at the University of Iowa. Thanks so much, Ben, for being our guest. If you know someone that would benefit by watching this program, it's going to be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and also the Mercy Cancer Center website. And Ben will also provide you a copy of this entire program, and you can use it electronically anywhere you would like on your media or within your health center. The next 2 weeks, we're going to be off for the holidays, so I'll see you back again in January. Thanks, everyone.